It is my privilege to introduce you today to our Patient Services Director. This is Shannon Sinclair. Shannon joined the foundation in October last year, so she and I have kind of grown up together in the foundation. It's been great fun. Shannon leads all of our direct patient services. She works with patients, families, and caregivers to help them navigate the diagnosis and treatment process. She helps refer patients over to mesothelioma experts because, as we all know, there aren't that many mesothelioma experts. Most of them are here, either virtually or in person. It's kind of the who's who of meso. But Shannon has really taken to all of this. She's got more than 20 years as an oncology nurse, has experience in pharmaceutical companies and in direct patient service, and has worked on clinical trials. So she is your partner in care. We hope that if you haven't yet reached out to her, if you have questions, she's here to support you. And she's developed a network of really great mesothelioma experts who can also help you as well. So without further ado, Shannon, it is your show. Have a great conference, everybody, and I'll be back shortly.
Good morning, everybody. So thank you all for coming here, and for everybody that's on the live stream, thank you as well. We're so happy that we got to put this conference on. It's been a long time in the planning, as all of you know. So today, for this session, I just wanted to touch on some topics that you may hear throughout the different sessions that are going to happen today. So some of you who have been with the foundation for a long time, hopefully this is a good refresher for you. And for some of you that are new to us or newly diagnosed, new caretakers, hopefully this will help you pick out some things that you may not have heard or that may not have made sense to you, so that as you listen to these sessions, you'll get a little bit more knowledge as we go. So we'll start with our first slide. Oh, that one doesn't move, sorry. So the basics are that there's 3 different cell types to know in the mesothelioma world. The first one is epithelioid. This is the majority of mesothelioma that we see. Approximately 50 to 70% of all cases. This does tend to respond better to treatment options that we have available. The second one is sarcomatoid. This tends to be only about 7 to 20%, very, very low numbers. It's aggressive. It does tend to be resistant to treatment, and that's due to the spindle shape of the cells. And then we have biphasic. Sometimes you may hear this called mixed. This is a combination of both epithelioid and sarcomatoid cells, and it makes up approximately 20 to 30% of all malignant mesothelioma. Looking at that. So I wanted to talk a little bit about staging and what staging is, because I get a lot of questions on this, and it's kind of difficult in the mesothelioma world. Simply put, staging is how to classify the advancement of a cancer. It can be a little tricky in mesothelioma. It's often referred to as TNM, and those are kind of the key letters when you're looking at, what your staging is. This stands for tumor, node, and metastasis. Each letter is assigned a value. So T is from 0 to 4. This looks at size and depth of your tumor. N is 0 to 2. This describes whether there's regional nodes or distant nodes involved. And M is metastasis. This has it spread outside of the primary region of disease. Also, does it involve any distant organs? Staging of disease is important because it is what drives much of the treatment plan. It helps decide things such as, are you a surgical candidate? Would systemic therapy be better? Will it be combination therapy? And are you eligible for clinical trials? So let's talk a little bit about systemic therapy and what is meant by that. So systemic therapy is a treatment that treats the whole system. It travels throughout the bloodstream, reaching cells throughout the entire body. There's a number of different systemic therapies that we see within the cancer world and within mesothelioma. So chemotherapy is probably the one that everybody has heard of the most. This is designed to stop cell growth. It's cytotoxic in nature. Chemotherapy cannot differentiate between healthy cells and bad cells. Examples of chemotherapy are like carboplatin, cisplatin, and Alimta. The next one is the immune checkpoint inhibitors. This has been a big topic recently in mesothelioma, and we're happy for that because we now have approved drugs in this space, which we didn't have for about 16 years. So this is sometimes referred to as IO. You may hear IO. These actually use the body's own immune system to fight the cancer cells. They are a little bit more specific in nature. And you may have heard of ipilimumab, nivolumab, or they can be called Opdivo and Yervoy. We also have precision medicine. So this is personalized medicine. It's based on the tumor morphology. This is a lot of where our research is headed. And this is a lot of where our clinical trials are going as well. And then we have targeted therapies. Again, a lot of research in this space in mesothelioma. Targeted therapies attack specific targets on cancer cells. So one of the ones that you may have heard of is Avastin or bevacizumab. This is what's called a VEGF inhibitor. It's vascular endothelial growth factor. And so it's looking for that specific receptor site on these cancer cells, and it's targeting those so that we can hopefully get less healthy cells that are being destroyed, and we're looking for more of just the tumor cells. So what is the what's meant by multimodality treatment? And you probably have heard this a lot. And this is basically combination therapy. It's very big in the world now. So we don't look to use just one treatment. We look to use several different ways of going after that tumor. So you may have chemotherapy followed by surgery followed by radiation. So we're looking at using an entire team to treat somebody, not just one specific way. There's also two terms that can be very confusing, adjuvant and neoadjuvant, and it's probably something that you've heard or that will be coming up. We're looking at a lot of this as well in research, but when thinking about these words, it helps if you know the goals of each of them. So the goal of adjuvant therapy is to reduce the risk of recurrence of disease. So it's given after the primary treatment. So this would be such as having surgery first, and then we're following it up by adjuvant chemotherapy. And that would be to rid the body of any microscopic cancer cells that may be hanging around. Neoadjuvant has the goal of helping that main treatment be more successful. So when we give neoadjuvant chemotherapy, the goal is to shrink that tumor down so that then when surgery happens, it can be a more successful surgery and hopefully less stressful on the patient as well. So I'm sure that you've heard the term first-line therapy. First-line therapy is the first treatment method that is being used. This is thought to be the most successful based upon what the guidelines have shown, what past research has shown. And then obviously after first line, we get into second line, third line, and sometimes even fourth line. I find that radiation is a very confusing topic for patients and caregivers as well. And it can be confusing for myself too because it changes. It's an ever-evolving field. But what you want to know is that basically what we're doing in radiation right now for mesothelioma is external beam radiation. It's a non-invasive form of radiation that treats a specific part of the body. Within external beam are several different categories. So many people have heard the term proton beam therapy, image-guided radiation therapy, intensity modulated radiation therapy. All of those fall underneath external beam, but they use a different machine. They use different techniques to go after those tumors or those cancer cells. The other one that you may have heard of, and that I'm sure that a lot of you who have done your own research have heard of, is what's called TTF. These are tumor treating fields. It's different from radiation, so sometimes people get confused and they think that they're the same thing. But TTF actually uses an external device that delivers low intensity electrical fields that disrupt cell division. So many of you have heard of like Novacure or Optune, and they are kind of coming into the picture for mesothelioma. So I wanted to go over a few surgical terms as well. So if you hear the word PD, that's pleurectomy and decortication. This is a lung sparing surgery, so that's a big thing to know about this surgery. It removes the affected pleural, all visible cancer from the surface of the lung and the chest, but it leaves that lung intact. EPP is extrapleural pneumonectomy. This removes that impacted lung. It also removes part of the pericardium, the diaphragm, and the parietal pleural. It's not used as much anymore, but you may hear of survivor stories where people have had EPP, and there are some physicians who still feel like it is an acceptable treatment. Cytoreductive or debulking surgery. This is something that you'll hear in peritoneal mesothelioma. It's the surgical procedure of choice. So this aims to remove much of the diseased tissue. So it's removing everything as possible that they can visualize. Two of the chemotherapies, ways of chemotherapies that you may hear as far as peritoneal goes, the first one is called EPIC. It's early postoperative intraperitoneal. Sometimes people refer to this just as IP chemotherapy. This is started shortly after surgery. It's usually instilled in several different spaced out treatments. So it may be given once a week. It may be given every couple weeks. They instill it, and then they drain it off through a port that they put inside your belly when they are done doing the surgery. The other one that probably most people have heard of is HIPEC, hyperthermic intraperitoneal chemotherapy. So this is actually given within the surgical suite after they're done with the cytoreductive surgery. They place chemotherapy into the abdomen, they circulate it through, they drain it off, and then they actually close up the patient. I wanted to dive into a little bit about clinical trials. I'm sure that you'll be hearing much of this today, and it does get a bit confusing, and especially for people who are new to mesothelioma. So clinical trials, you will sometimes hear them be called research protocols. They are to evaluate an intervention for an effect on a health outcome. It might be a new medication, it might be approved treatments for another tumor type. It might actually be looking at a treatment versus a placebo. It's designed around a protocol, and these protocols lay out what's going to be done in this clinical trial. So we have the objective. So if you're ever reading a clinical trial and you see the objective, it's the why. It establishes the question that the clinical trial is trying to answer. The methodology is how they plan to execute that trial. And then the outcomes is probably what you are primarily looking for on these. These are the endpoints, these are the results, this is what they're looking to obtain. So you may hear things such as like OS, which is overall survival, PFS, which is progression-free survival, ORR is objective response rate. We have CR, which is complete response, and PR, which is partial response. The reason why I bring those up is because I think they're really important to people when they're looking at quality of life, because sometimes you want to look at where did people fall into these categories in these clinical trials. Most trials also have arms. And I know that I tend to speak sometimes about the arms of a trial, and then I have a patient or a caregiver say, I'm not really sure what that is. What are you talking about arms? And this refers to the different groups within that trial. So this would be looking at somebody who was getting standard chemotherapy, that may be one arm, and then the other arm would maybe be looking at somebody that was getting immunotherapy and chemotherapy. And then you may have a third arm that looks at a placebo plus the chemotherapy. So some of them can have many arms. Some trials only have one or two arms. Just depends on what, again, the objective is looking for. So the majority of trials that we see are considered randomized. This is when participants in the trial are placed into a database, and they're selected at random for the different arms. This is sometimes what determines eligibility. So, you may see where there's chemotherapy or chemotherapy and immunotherapy. And sometimes if you've already failed one of those, you may be just ineligible because of how the randomization takes place. Non-randomized clinical trials, these are participants that are placed into different arms using controlled methods. There's 4 phases of clinical trials. This is really big to know as well, especially when you're researching clinical trials for a loved one or for yourself. Phase 1 evaluates whether the intervention is safe. This is usually the first testing in humans. Phase 2 evaluates the effectiveness on certain types of cancer and the safety. Phase 3 often compares that effectiveness against what the standard of care is today. And stage 4 usually looks at long-term follow-up. So what are we seeing after the approval? What are we seeing years down the road? Many trials are approved under an accelerated approval, and that's because the outcomes have been significant that they've seen in the beginning. So a few presentations today are going to focus on genetics and mutations, and this is really the future of cancer research as well as mesothelioma. So I wanted to touch base on these because I find them to be kind of confusing. So germline mutations, this is a mutation that is inherited from both or one of your parents. It is there at conception. It can also be passed on to your offspring. This is sort of where we look at prevention and what we can do to screen people for things in the future. So examples of this are like BRCA1 and 2, Lynch syndrome, cystic fibrosis as well. Then we have somatic mutations. These are genomic alterations that occur after conception. They're not inherited. You do not pass these on to offspring. They often happen in the process of cancer actually forming. So many of you have probably heard of ALK, EGFR, BRAF mutation, HER2. This is where much of the targeted research is going, and so you'll probably be hearing a lot of some of the somatic mutations. NGS is the next generation sequencing. You will hear about this today. This is Foundation 1, Guardant 360 are just 2 of the examples of those that some physicians may use. So this uses tissue, blood, saliva samples, and it's looking at what those gene mutations are. And it's very, very important into the emerging treatment options in the clinical trials that are happening right now. So novel therapies. This is personalized medicine. This is looking at those specific mutations that a person has. So this is not lumping everybody into one category. This is actually saying we're looking at you specifically and what variants do you have, what mutations do you possibly have, and then we're going to drive our treatment plan around that. So personalized medicine. Gene therapy is a treatment approach that alters a gene. These are very emerging approaches. So immunotherapy, virotherapy, gene transfer, some of the vaccinations that you've seen in the cancer spaces. And another research focus is TME. This is tumor microenvironment. This is important because we're looking at what's surrounding those tumor cells. What are the blood vessels around it? What's feeding these tumors, and how can we stop them from doing that? We want to see what the immune cells are doing around those. And it's important when understanding the initiation of those tumor cells as well as the progression. That's it. I just wanted to thank everybody for attending. it's wonderful to have everybody here. It was great to meet some faces that I've seen and known and that I've talked to on the phone. And it's really a pleasure working for this foundation. I've really loved coming into this. I know I have big shoes to fill with Mary, but I think that hopefully working together with this team has been great. So thank you so much for attending.